invasive surgery training program. It's a fellowship program we're running in the Philippines for advanced laparoscopy. The hospitals are 3 government hospitals in Manila and 1 in Batangas City. So it's Rizal Medical Center, Quirino Medical Center, and Batangas Medical Center. Unified minimal invasive surgery. So all in all, it's like a 1,600 bed something. We have smaller hospitals, unlike in Korea or Germany or China, where you have a lot of 1,000 plus beds. Here we have smaller hospitals, so we have a unified program for the 3 hospitals for minimal invasive surgery. So thank you for joining us and for helping our fellows and our residents. The participants actually would come basically from the 3 training centers, but some doctors around the country would also join us. They would usually log in and then watch the lecture. They really like the lecture series that we're giving, so we're also sharing this webinar to them. So I would like to, in behalf of the UMIST program and the 3 chairmen of the 3 hospitals, we would like to thank all of you for joining us. Of course, we have Duday, Dr. Navarro, Dr. Orlina, and Dr. Ronson as our local experts for gastric surgery. Emong is quite noisy. No, Emong, you need to say something. Hello, Emong. Emong, I think you're on mute.
Anyway, Emong will be the moderator for next week. So.
I think the 3 of you should,
Yeah.
How do you do this? I don't know how to do this. Okay. Good. So we start at, Duday, you want to start at 7 o'clock?
Yes, sir. So 4 minutes to go.
Wala pa yata sila Ray, no? We're just waiting for the...
Wala pa, sir. Nasa 25 pa lang tayo. Siguro mga 7:05 then.
Yeah.
Or we can give another 5 minutes. Usually they would log in on time, right?
Yes, sir.
Philippine times or just on time?
Philippine time or Germany time?
Yeah, Philippine time.
Still on Felix, you're still on lockdown?
I'm sorry?
Germany is still on community quarantine?
No. Just the country is not in lockdown, but we react to local situations locally. So there is a cutoff of 50 cases per 100,000. If any a local area goes beyond that limit, you have to react with some measures. But there is not a real lockdown anymore. But the cases are increasing in Germany. It's not out of control yet, but the people were going to vacation in the summertime and coming back, and now we have the majority of the positive cases are coming from abroad.
Yeah.
And it was probably a mistake to let the people go on the summer vacation. Yes,
that's true.
And church too. We didn't go because of this issue. We hope to have a vacation next year, but it doesn't make so much sense this year. 60 to 70% of the cases now are because of this leaving the country in recent time.
Yeah, even the Philippines, the new strain of the coronavirus actually comes from the outside. So from returning residents. I think
but I think for the Philippines is a special situation because you have so many abroad workers, and probably some of them have to return because of the situation in the specific country where they're working, and maybe they have to leave the corona situation. So I think it's a different situation. In Germany, the people were going for vacation, for pleasure, but I mean, this is maybe unnecessary.
That's very true.
So,
I think
yeah. But
the
in
only
my area, we didn't have a problem. We prepared for everything. We also prepared to shut down the OR, which was not necessary at any time. We prepared to use the OR as another intensive care unit. We didn't. It wasn't absolutely not necessary to do so, and we even helped to treat patients from Italy or Netherlands or Belgium or Spain. Because we didn't have our own patients in this area of Germany. So we have been very lucky so far, but anytime it can change.
That's very good. I think the only country that's not on a watch list is China. China was able to really control it, right?
Yes, very strong control by Communist Party,
Any updates on the vaccine, Professor Chu?
Maybe the end of this year, the vaccine will be published, and so we are waiting for it.
We also have two vaccine companies in Germany running phase 3 trials. One is from Mainz, actually the city where I'm now living in, and they are starting to vaccinate 30,000 people in a phase 3 trial, and are also expecting to have that, if it's effective, to have the results early next year.
How about vaccine in Korea, Professor Kim?
Actually, I'm not having a very good reception right now.
Yeah.
Can you repeat the?
Yeah. Any vaccine updates from Korea?
Oh, the corona.
Yeah, Corona.
I heard that they're doing a mass production of corona vaccines starting end of this month. Has been the actual generics from the Moderna from USA and AstraZeneca from British.
Yeah.
So they're starting to make vaccines, but there are two kinds of strategies to go through this kind of situation. One is to contain the population, and number two is to not containing the population and make them have much more contact with the virus so that they can have more herd immunity. But our population went through the first option, and I think we kind of failed in that road. So now we're facing a very high peak of infection all over the country. So it's very hard to say that the ends will be optimistic at the moment, but I think our government's doing our best, and all the medical workers are doing our best. So just hope for the better side at the moment.
I can tell you then the neighboring countries in Europe that were trying to do the herd immunity thing were failing much more. So probably not.
Yes.
I think probably Korea was doing very, very well. And
Spain.
I think in
Yeah.
Korea, the people are already a little bit used to some measures like mask, which is completely new to people in Europe, suddenly to wear a mask. And some of them, they celebrate their freedom by not doing this, which is kind of silly. But I think it is just not it is maybe not manageable to have the whole population infected at the same time. But if everybody gets infected one after another slowly, I'm very sure Korea will manage very
Did you
very
see
well.
the celebration last night, in Paris, when PSG won? Oh my God, that was like, knowing that you have Corona,
Yes.
and everybody was celebrating
Yes,
near the Champs-Élysées. Oh my God.
soccer games are the biggest threat in Europe for any Corona.
Even Germany, mind you, Felix, when you won the other day, Bayern Munich against Barcelona,
Yes,
my God, the celebration in Germany was
Yes, but it was a very special win because it was 8-2. It's historical. So it's different from the Paris thing.
With Barcelona. Incredible. 8-2.
But actually, celebration is not forbidden right now in Germany. The soccer games are under isolation. In Portugal, the Champions League and the other European Cup is in Germany. But there is no spectators to the games, but going to a public place and watch the game and celebrate is not forbidden right now.
So I think it's 7:05.
I think we can start already.
Yeah.
At kami.
Pwede na, Felix?
Pwede na, Felix.
Pwede na?
Ako?
Magsimula na tayo, Felix. So anyway, I think the three chairmen of the departments of surgery from Rizal Medical, Batangas Medical Center, and Kirin are here. So I would like to welcome once again, everyone on our third gastric session for the UMIST, Unified Minimally Invasive Surgery Training Program. This is the third series, right, Ronson? We would like to first, of course, thank the group of Ronson, Duday, Dr. Navarro, Dr. Erlina for putting up the program like this. This is some sort of a reunion for the gastric group, the Korea gastric group. I think it's a big reunion for them. These are the rising stars of gastric surgery all over the world. We would like to thank, of course, Felix Bert from Germany, Professor Chun Chazu from China, and of course, Tai-Han Kim from Korea. We're still waiting for Sang-Hoon Kim. We just received a message from Sang-Hoon. He's now in emergency surgery because he's on duty, and he scheduled 7 cases for today. The problem with Sang-Hoon is nobody can take over his surgery because he's doing a solo surgery. Nobody can take over the surgery that he's doing. So anyway, if Sang-Hoon would come in later at this time, we would be more than happy to have him, of course. If not, we'll be expecting Sang-Hoon next Thursday for the last series of gastric lectures prepared by Dr. Navarro, Dr. Ronson Ang, and Dr. Erlina, the gastric group of the UMIST program. So anyway, without much further ado, Ray is here. Can we ask Ray and Dr. Palines to say hi to everyone? Ray Sarmiento, Professor Ray is the chairman of the Department of Surgery for Rizal Medical Center, one of the big government hospitals in Metro Manila. Ray?
Hi, good evening, everyone. Good evening, Professor Joe, Professor Kim, and kamusta, Felix? How are you?
Mabuti na lang.
So we'd like to welcome you in this UMIST lecture series, webinar series. And we're so thankful that you graced this lecture series with us. I hope tonight will be very interesting. So without just eating up the time, I will probably pass the mic to Dr. Palines, the chairman of the other hospital who is part of this UMIST program. Sir Allen, may I pass the mic to Dr. Palines? Welcome everybody. Thank you very much, professors. So I'll pass the mic to Dr. Palines.
Sir, Dr.
Okay, good evening, everyone. Again, Alan, thank you for bringing in the experts and to Professor Zhu, Professor Dr. Bert, and Dr. Kim, Professor Kim. Welcome to the Philippines, at least virtually. And we hope we will not sooner or we will see you face to face. So again, good evening, and I'm sure with the topics lined up, this will be a very interesting night. Thank you.
Thank you, sir. Thank you, Ray, for that welcome remarks. Anyway, we promise you a very fruitful night lecture series for tonight. So we would like to start without much further. I would like to give you now to Ronson and Dr. Navarro and Dr. Lina, who will be presiding over the lecture series. Bernice,
Yes,
Duday.
sir. Thank you.
Thank you.
Good good evening, everyone. We would like to welcome you to the weekly teleconference lecture series of UMIST. So for tonight, we have the third part of our gastric cancer lecture series. We have four distinguished guests. I would like to introduce our first speaker. So for our first speaker, um, since 2008, Professor Zhu has been with the Department of Surgery, Renji Hospital, Shanghai, Jiao Tong University School of Medicine, and from then on, he has been mainly engaged in the surgical treatment of gastrointestinal malignancies. He has devoted his research into gastric malignancy, especially the pathogenesis of gastric cancer and the mechanisms of recurrence and metastasis. He has carried out a number of national natural science funds, such as the Shanghai Science and Technology Commission, the Shanghai Health and Family Planning Commission Research, and he has been this principal investigator or its main participant. From 2013, he started his PhD project, which focused on the genetic alteration of liver metastasis in gastric cancer. Through the experience of his PhD research, he has been familiar with the research methods of bioinformatics. From the October 2016 to October 2017, he has worked with and studied in the Seoul National University Hospital as an international fellow. He has 15 publications, mainly on gastric cancer research. He has won Best Poster in the 12th International Gastric Cancer Congress of 2017 in Beijing, with the paper titled The Clinical Outcome of Manual Dilatation of Pylorus in the Pylorus Preserving Gastrectomy. Currently, he is the Associate Chief Surgeon in the Department of Gastrointestinal Surgery at the Renji Hospital, Shanghai, Jiaotong University School of Medicine, and he continues to share his passion for surgical oncology, especially for gastric cancer and gastrointestinal stromal tumors, laparoscopic gastric cancer surgery, and also in research on gastric carcinogenesis, cancer metastasis, and tumor immunology. To present his lecture on the pylorus preserving gastrectomy, let us welcome Professor Chun Chao Zhu.
Okay, thanks for introduction. So I need to share my screen. Okay. Now, can you hear me?
Yes.
Yes,
Yes,
let me start. So, good evening, dear Filipino colleagues. I'm Dr. Chun Chao Chu from Renji Hospital, Shanghai Jiaotong University School of Medicine. It's my great honor to be invited here to share some information about pylorus preserving gastrectomy in my country and some of our work on PPG. Nice to see, very happy to see Dr. Ang, Dr. Kim, and Dr. Felix here online. The time spent with you are very precious memory for me. So until now, PPG is majorly reported in East Asia. Japanese surgeons firstly reported the PPG operation, formulate the indication of PPG. Korean surgeons actively applied the PPG surgery in indicated patients, made a great contribution to popularize the PPG, especially organized a randomized control trial for PPG. In China, although the diagnostic rate of early gastric cancer is only about 20%, China still has the biggest volume of gastric cancer patients of 3 nations. That means PPG will have the large targeted patients. We think China will have a big number of PPG in the future. So in China, gastric surgeons are trying different kinds of function-preserving gastrectomy, including partial gastrectomy, segmental gastrectomy, proximal gastrectomy, and other local resection. But these reports are mostly focused on the PPG, which is considered as a typical function-preserving gastrectomy. The first PPG case is reported by Professor Markin in 1967, which shows a satisfied outcome on gastric ulcer patient. Since the third version of Japanese guideline for gastric cancer treatment, which published in 2010, pylorus preserving gastrectomy became a typical gastrectomy for middle third early gastric cancer patient. The guideline determined the indication of PPG operation and standardized the lymph node dissection of PPG, which could be considered as another milestone of PPG. Professor Han Kwang-yang from Seoul National University Hospital has made a great contribution in propelling PPG internationally. Seoul National University Hospital is leading in PPG worldwide with case number and the studies. Also, Professor Hyuk-jun Lee is in charge of class 04, which has completed recruitment. Related results are expecting to be published in high impact factor journals. Professor Hu Xiang from First Hospital, Dalian University, is the first surgeon who reported PPG to Chinese colleagues in 1990s. He is actually the pioneer of function-preserving surgery for gastric cancer in China. Dr. Hu Xiang continued to introduce his experiences, technique essentials of PPG operation, and published the data of his PPG patients in recent 20 years, which gave the Chinese surgeon the concept of function-preserving gastrectomy for early gastric cancer. According to the China Gastrointestinal Cancer Surgery Union data, the early diagnostic rate of gastric cancer is about 20%, although the percentage is still low, but it is continue increasing every year, and the number of early gastric cancers in China is more than 100,000 per year. That means function-preserving gastrectomy might be widely applied in Chinese patients. Preoperative precise cancer staging and the tumor localization are necessary for PPG. At present, the imbalance of medical developing level still exists in different provinces of China. It is difficult for the primary hospital to practice PPG, so most of the PPG cases are performed in the big centers. At present, PPG surgery is majorly performed in the top hospital in a few developed cities in China, mainly in major center cities such as Shanghai and Beijing. However, the concept of PPG in the treatment of early gastric cancer and the function preservation has been widely accepted by Chinese surgeons and gradually standardized. China's first version, expert consensus of PPG surgery, has been published in 2018. In my hospital, my boss, Professor Cao, my senior Professor Gang Zhao, and other of our faculties, including myself, we continue to study in Seoul National University Hospital as visiting fellow to learn the function-preserving surgery. Then our center has the largest volume of PPG cases in China in recent years. Of course, we are not only simply imitate the surgical procedure, we try to merge some of our own thinking to this operation and practice it with our own style. This is our data, which shows the outcomes of 101 PPG cases from 2015 to 2018. This is at the beginning of our practice of PPG. Most of the cases are early gastric cancer confirmed by post-operative pathological staging. There are only 5 cases in staging 2A. According to the result of resection in different lymph node stations, lymph node metastasis is mainly focused on station number 3 and number 4D. And the numbers of lymph node resection and the metastatic rate are similar to previous studies. There is no recurrence nor metastasis in all the patients. This says PPG is oncologically safe. According to the 1-year follow-up for these patients, although incidence for gallbladder stone formation is about 7.9%, post-operative gallbladder stone emptying, gallbladder emptying rate, stomach emptying time, and 2-hour post-meal stomach residual food rate are similar to preoperative ones. Result shows gastric function preservation is acceptable. Post-operative complication in our cohort seems also acceptable. There are 18 patients had complication, among which the incidence of gastric emptying disorder is about 7%. As we all know, delayed gastric emptying is considered as a significant complication after PPG. Emptying disorder delays the recovery of patients after PPG. Many gastric surgeons is worrying about this particular complication. Thus, preventing delayed gastric emptying after PPG is a key problem of PPG application. Knowledge from the literature shows that length of entrance curve is related to the incidence of delayed gastric emptying. When the entrance curve is more than 3 centimeters, the incidence of the emptying disorder reduces to 6 to 8%. On the other hand, it has been proved that infrapyloric venous flow is related to the incidence of delayed gastric emptying. Preserving infrapyloric vein can reduce gastric stasis after PPG. In addition, such as how to exactly preserve the function of the hepatic branch of vagus nerve should also be considered, so as to minimize the thermal damage to the nerve when using the energy device. In our view, the motility of distal remnant stomach after PPG required adequate blood supply and the venous flow of pylorus and the enteral curve, which will maintain its vitality and prevent the edema of the enteral wall. Because of that, infrapyloric lymph node dissection should be one of the key procedures in PPG, which require complete dissection of number 6 lymph nodes and carefully preserve the infrapyloric blood flow. So with our experiences, we recommend to preserve the entrance curve to 5 centimeters if possible. 5 centimeter distance to pylorus can reduce the influence to the mortality of pylorus from the anastomotic scar tissue. Of course, 5 centimeter to pylorus means we narrowed the indication of PPG surgery, which can apply in the tumor lesion 4 cm to pylorus. Another procedure is that we preserve the first branch of the right gastric epiploid vein, except the infrapyloric vein. We call this vessel, we named it enteral branch. From the observation of recent dozens of patients, we found that the end flow of gastric wall 5 cm to pylorus is almost from the enteral branch of right gastric epiploid vein. That makes sense why we need to preserve more venous flow of distal remnant stomach. One more branch preservation, except infrapyloric vein, will definitely protect the venous flow and reduce the edema of enteral curve. Combine the knowledge we have, we made modifications in procedures. During the surgery, preserve more blood flow of pylorus and enteral. Maintain sufficient enteral length while making the anastomosis. Evaluating edema on gastroenteral before the anastomosis. If there is significant edema or the enteral wall is significantly thickened, then we will give up PPG and convert to distal gastrectomy. Then I will talk about the operation procedure of LPPG in China. Different from Japanese and the Korean surgeon, left side is the common position when Chinese surgeon performing laparoscopic gastric surgery, including LPPG. Right or left side position has their own advantages of the LPPG. Actually, Chinese surgeons used to do laparoscopic gastric cancer surgery from left side, including total gastrectomy or distal gastrectomy, not only in PPG. In LPPG surgery, our experience is that operation from left side is much easier for infrapyloric dissection and venous flow protection. When performing infrapyloric dissection from right side, energy device is perpendicular to infrapyloric mesogastrum. It is not convenient for the operator to do number 6 lymph node dissection, especially in number 6I and number 6V dissection. When the operator is from the left side, the energy device is parallel to infrapyloric mesogastrum. It is easier to separate the fusion layer of mesocolumn and mesogastrum. Also, it is convenient to expose and protect venous branch while performing number 6I and the number 6V dissection. Okay. This is the video clip of infrapyloric dissection of PPG operation from right side. From the video, we can see right side position is not bad for the number 6A station dissection because the energy device can easily go inside the tissue beside right gastric epiploic artery. When the energy device is parallel to the surgical plane of the dissection area, it will be much easier to approach the dissect layer you want. However, when performing number 6I and number 6V dissection, the energy device is perpendicular to the surgical plane, which make it a little bit difficult to deal with. Moreover, PPG from right side is always dissected along the infrapyloric vessels from proximal to distal. That is also the differences from PPG from left side. This is the video clip of infrapyloric dissection with entrance branch of right gastric epiploid vein preservation from left side. We can see that the energy device comes from left side and which can easily separate the surgical plane between mesocolumn and mesogastrum or mesoduodenum. The advantage of left side position is that the energy device parallels to the plane of the head of pancreas, which make it more convenient to dissect number 6V lymph node. Here is number 6A dissection. So the energy device is a little bit perpendicular. Oh, here is number 6I and the 6V dissection. It will much easier for energy device to go inside because it is paralyzed to the surgical plane. And here is number 6A dissection. The energy device is a little bit perpendicular to the surgical plane. So here it is not very safe and a little bit difficult to deal with. And similarly, when the assistant lifts up the proximal duodenum, it is much easier for the operator to dissect along the branch of right gastric epiploid vein when performing number 6I lymph node dissection. Here, almost the final view when finishing infrapyloric dissection. And here first branch is just we call entrance branch of right gastric epiploid vein, which is preserved. Concerning about the dissection of other area, there are also some differences. For the suprapancreatic dissection, right side operator position start from common hepatic artery. The assistant need to lift up the left gastric artery, and the stomach need to push to the left side when the suprapancreatic area can be completely exposed. The left side operator position dissected start from proximal splenic artery. the assistant need to lift up the left gastric artery together with the lesser curvature of the stomach. So different position may make differences of direction, traction, or exposure for dissection. But I think both ways are feasible and efficient in suprapancreatic dissection. So the left side position. Here is left gastric vein. The right video. Here is number 6A dissection. Anyway, both of these two positions can do suprapancreatic area dissection feasible. Okay, done. For greater curvature side dissection, the energy device direction from right side seems to be more convenient because of left side position has limited space to move the energy device. And the exposure is more depending on the traction by assistant. This is a small video clip of greater curvature side dissection. We don't want to say that the left side position is better than right side. There are many Korean and Japanese surgeons. They did very good PPG operation from right side. In our view, for left side operator position, the biggest advantage is that it is more convenient and efficient in infrapyloric dissection with our modified procedure. After we adjusted the strategy to prevent delayed gastric emptying, including preserving enough length of entrance curve to 5 cm, preserving entrance branch of right gastric epiploid vein, and routinely preserving the hepatic branch of vagus nerve, the incidence of delayed gastric emptying is decreased to less than 4%. Only 2 cases occurred in more than 50 LPPG patients. We are summarizing these data and will publish it soon. Except the routine way of PPG surgery, we also try to use some additional technique to make the surgery more accurate and effective. This is the ICG fluorescence navigation technologies. It can play a unique role in PPG. ICG imaging can effectively help lymph node dissection at infrapyloric area. If necessary, angiography can be used to evaluate the preservation of blood vessel at infrapyloric area and to maintain the blood supply of entra and the pylorus. This is a final view when we finish the dissection. Lymph nodes are complete dissected. On the basis of our retrospective study, we carry out prospective RCT studies. Our center has applied for the related RCT on clinical trial to clarify impacts of LPPG on patients' post-operative quality of life. 1 year gastric emptying rate is the primary endpoint. This is my summary, but I want to say that defining the concept of PPG to function preservation is more significant than its actual clinical meaning, because we all know the core of minimal invasive surgery concept is not how much we dissect, but how much we can preserve. That's all I want to share with my dear Filipino colleagues here. Thank you very much and wish everyone stay safe from COVID-19 pandemic. Thank you very much.
Thank you, Professor Zhu. we'll just proceed with the next speaker. We'll hold all your questions for Professor Zhou on the end of the session. If you would like, you can type your questions in the chat box, and then we'll have an open forum after all our speakers have presented their lectures. So for our next speaker, I would like to introduce to you Dr. Felix Berth. He had his medical training in the University of Medicine at the University of Cologne in Germany. And I met him when he had a part of his medical internship at the Philippine General Hospital, where he did his appendectomy. So it's the first time I met Felix. So, and then he pursued his further surgical training at the Department of General, Visceral, and Cancer Surgery at the University of Cologne under the tutelage of Professors Holscher and Professor Bruns. For the next 2 years, he was in South Korea, where I met him again, where he had the research scholarship, and he was a fellow in the he was a research fellow in the Division of Gastrointestinal Surgery at the Seoul National University Hospital under Professor Yang. He has won several international awards, the latest of which was a travel award from the Japanese Society of Gastric Cancer during the Japanese Gastric Cancer Association meeting last February of 2019. He has also been invited in several countries to give a lecture, such as in Poland, Portugal, and in Korea since 2010. So he has 45 research publications worldwide. And since then, he has been with the Department of General and Visceral and Transplant Surgery at the University of Mainz in Johannes Gutenberg University in Mainz, Germany, with Professor Lang as the head of the upper gastrointestinal function diagnostics. Doctors, let us all welcome a good friend of mine, Dr. Felix Berth.
Maraming salamat, Ma'am Duday, for this very kind introduction. I'm trying to start my slides. Hope you can see it. Thank you very much again for this very kind invitation. It's a great honor and a personal pleasure to have this talk here today. And I would like to talk about minimally invasive surgery for esophagogastric junctional tumors, how we do it in Germany. Certainly my experience are highly influenced by the surgery that I have seen in Asia, mostly in South Korea, in Seoul National University Hospital, where I met all of you basically, but I'm also giving you an impression how we do it in Germany, and you also warmly invited to join us and see how we do it. So, 1 second. Now, this is my situation now. Professor Lang is the chairman himself. He is a hepatobiliary surgeon. I would like to introduce my senior and head of upper GI cancer surgery, Professor Grimminger, who is an important person for me personally, but also maybe for the upper GI surgery in Germany, because he established, he was the first to establish the routinely performed, totally minimally invasive esophagectomy for junction, also for esophageal cancer. Right now, we have approximately 300 cases of upper GI diseases, including malignancies and also benign disease. And I think we are doing a good job to also recruit in the international prospective trials, evaluating the role of minimal invasive surgery for upper GI cancers in in Europe and in the world. So I'd like to start with a classification that was brought up in the 80s by one of my first boss, Professor Hölscher, who was a junior of Professor Sievert, and he was establishing the Sievert classification. And the Sievert classification is well known, and we do use it for the classification of EG junction cancers. It is a classification which is used for adenocarcinoma, as we do see adenocarcinoma mostly in the esophagogastric junction, which is a little bit different from East Asia, where also squamous cell carcinoma would occur in the distal esophagus or even in the junction, which we hardly see in the West. So the classification was brought up for adenocarcinoma, but it's anatomically based, so it can easily describe a localization of tumors. It describes tumors that are touching the junction, and the classification refers to the highest tumor burden, which is to be in the distal esophagus, called type 1, which is directly in the, we say, cardia, or in the transition zone, which is type 2, or it is more a proximal gastric cancer with a higher tumor burden in the stomach, which is type 3, which is important, which was important to classify because back in the days, patients with cancer in this area would have undergone esophagogastrectomy, which was a very burdenful operation with a high mortality rate. So the basic idea behind this classification was to reduce the mortality or morbidity on operations of cancers in this area. And the basic idea was to say that and to perform a esophagectomy with proximal gastrectomy for type 1 cases, a extended gastrectomy, so a gastrectomy plus distal esophageal resection for type 2 and type 3. This was the first idea, which was based also on data on lymph node metastasis on the mediastinum. But nowadays, more and more, the type 2 is very much in discussion. And we have a prospective randomized trial running now in Germany, evaluating if the esophagectomy or the gastrectomy is performing better on patients having the cancer directly in the EG junction, which is I think, surgically very interesting question. Now, before I show some pictures and videos, I just want to summarize how we do treat patients with locally advanced cancers multimodally. And this is kind of different in different parts of the world, where the US is still sometimes performing postoperative radiochemotherapy. In Asia or in Japan, namely, there is many studies for postoperative chemotherapy on junctional cancers, and we do not perform this. We do perform perioperative chemotherapy mostly. So 4 cycles of chemotherapy before operation, followed by the operation, and then, if possible, 4 cycles of chemotherapy after the operation, which is just recently brought up by the results of the FLOT4 trial, which I will a little bit introduce later, or now. So the FLOT trial was one very important trial to establish the perioperative chemotherapy in locally advanced gastric cancer, including patients with junctional cancer. And the CROSS trial, which was published in 2012, I think, in New England Journal of Medicine, was bringing up the idea of neoadjuvant chemoradiation for esophageal, distal esophageal cancer, including junctional cancer. And now we still have the situation where we don't know which is more effective for our patients, and we do have finalized recruiting a prospective randomized trial for comparing both regimens. But I want to summarize the characteristics of both. So in the FLOT trial, more than 40% would complete the FLOT, the 8 cycles, which was better than the standard chemotherapy ECF, which was established after the MAGIC trial in 2005. But the disadvantage of this trial for the junctional cancer is that mostly gastric cancer was included in the trial. In the CROSS trial, there was a higher percentage of junctional cancers included, but the surgery was not standardized. So the kind of resection, the type of dissection was selected liberally, and there has been only performed a quite limited lymph node resection, because we know that the median numbers of lymph nodes harvested in the chemoradiation arm was 16, and then the primary operation arm was maybe 18. Another problem in this trial is that in the primary operation arm, the R0 resection rate was only 69%, which is due to very, very advanced cancers in the trial, but also possibly to not very effective surgery. Now, as I know that you are speaking to the very masters of gastrectomy, and Dr. Chu also shared a little bit about functional and stomach preserving surgery, I want to introduce the proximal gastrectomy plus double tract reconstruction, which we also do now in Germany for earlier cancers in the junction. We do have a lot of cancers in the EG junction in Europe. Mostly are locally advanced, so are going for total gastrectomy if so ever, or esophagectomy, depending on the localization, which I mentioned before. But if we have a more early cancer that we can operate primarily on, we do have a very good option to perform a proximal gastrectomy, because the distal stomach is free of cancer, and the risk of lymph node metastasis in that area is very low. So I learned the proximal gastrectomy and double tract reconstruction from my teachers in Korea. I was very proud to be an international fellow in SNUH with Professor Yang. And I was also very happy to see how Professor Park is doing the proximal gastrectomy, who is the PI of the now I think the class 05 trial, which was comparing proximal gastrectomy with total gastrectomy for upper third early gastric cancer. And I think the study finished recruiting last year. And you see the principle of the operation and the specimen. I think the indication is important because it should not easily be extended to advanced cancer, which is dangerous because of the risk of lymph node metastasis in area 5 and 6, for instance. But if you have a case where the indication is clean, you can preserve easily half of the stomach. The luminal resection is mostly not the problem, especially if you have cancers in the EG junction. So you do have, compared to the total gastrectomy, you do have one additional anastomosis, but you do spare a duodenal stump, which is also nice, and the anastomosis is not a high-risk anastomosis as it's gastrojejunostomy. Now, how did this operation come to Germany? I again want to appreciate the input of our Korean friends. My former boss, Professor Hölscher, visited me in Korea in 2018. We both observed this kind of operation, and when he came back, he would perform the first one probably of this operation in Germany, and directly published his results. And regarding the literature, this is how the proximal gastrectomy and double tract came to Europe. Now, again, this is for you, this is a picture that you can memorize how the reconstruction is done. And it's under debate what should be the ideal length between the anastomosis. In Germany, as we do have more obese patients and a high incidence of reflux, we would probably tend to have this area a little longer than 10 centimeter, but it's quite too early to say definitely what would be the perfect length. And this is how it is described. Now, first I show some pictures intraoperatively. This is the transection of the stomach. So you see a good portion of the stomach is remain. This is clipping of the left gastric artery, and you can see that even though the distal stomach is preserved, there is no compromise to the suprapancreatic lymph node dissection. And certainly the principle of any operation for junctional cancer is to have a low mediastinal lymph node dissection. You can see the transected esophagus already here. And here you see the side-to-side duodenogastrectomy, which is performed with a stapler. In this case, it was laparoscopically. I'm sorry for the bad quality of the pictures, but I had to take it from the video, which I was not able to cut in the to edit in the very short time. But you can imagine the anastomose is very wide and needs only the stapler opening needs to be closed with a V-look. And I was, regarding the limits of minimal invasive surgery, regarding in respect of radicality, I was also impressed by another surgeon in Asia, which is Professor Ming in China, who is performing a lot of splenic hilum lymph node dissection very aggressively. And it gives me and you an idea that regarding the oncological radicality, minimal invasive surgery is no compromise at all. And next, I want to share the video of another proximal gastrectomy double tract reconstruction, which was done robotically last year. And we performed it a little bit different than the one that you have seen with the picture. Now the transection line was shown. We start the operation usually at the lesser curvature site at the hiatus. To have a clean margin, I have to stop the video to explain. In this situation, you like to start the operation probably on the junctional area, because if you are not sure that you can get a clean margin via gastrectomy, you can get the proximal margin first, send it to frozen section, and if you have a clean margin, you can proceed with a gastrectomy, either total or proximal gastrectomy. But if you cannot have a clean proximal margin, then you can change your strategy and go and perform esophagectomy, because you have preserved all the vessels here and the arcade at the greater curvature. So if you start at the greater curvature side and you cut the arcade, then you cannot change the strategy intraoperatively, even if you cannot get a clean margin proximally. So this is why we sometimes a little bit change the steps of the operation now. And now, as we know or are very sure, we can do a gastrectomy. We perform the omentectomy and release the stomach from the short gastrics or from the spleen. And now this is transection of the stomach. We do probably leave a little bit less stomach than our Korean colleagues. In this case, it's quite okay, I think. Then this is the suprapancreatic lymph node dissection, which we do perform mostly with a monopolar hook, which is a very nice device. It can also be done with a energy device, certainly. We feel very comfortable with this device, especially in the robotic surgery, but it's not a dogma. It is just how we like to do it. Okay, this is the transection of the esophagus, and followed by the splenic hilum lymphadenectomy. So you can see that it can be done properly with a robot as well. And this is the, maybe I get the picture here. Okay, it's over. So this was the number 10 dissection. And now you probably cannot see anything, which is kind of a problem for the very high anastomosis. This is the esophagoduodenostomy. it is challenging if it's so high. I cannot share the perfect method for this anastomosis so far. And in this case, in contrary to the other case that you have seen with a robot, it's very comfortable to even have a Hansun anastomosis for the stomach in this case. Maybe it's a little, the stapler anastomosis is a little bit wider, but I think it's sufficient, and it's also convenient. Maybe a little bit more convenient than with laparoscope, but it's also possible. It's not a limitation. All right. Now again, I want to change the localization of the tumor a little bit to the, because junctional cancer also includes type 1 cancer, which has the highest tumor burden in the distal esophagus. So for this, we do perform the Ivor-Lewis esophagectomy routinely, minimally invasive, and we perform it robotically. We call the operation Ramir 4, which is the robot-assisted minimally invasive esophagectomy with a 4-arm technique. The 5th arm is for the assistant, or simply the laparoscopic thoracoscopic minimally invasive operation. You see that the trocar position in the abdominal part is a little bit different. It's a little bit more straight in the robotic operation, and we put the trocars a little higher in the laparoscopic gastric mobilization lymph node dissection because of the angle, and also we want to dissect the lower mediastinum already, and we need to have a good angle and a good length, because sometimes people are quite tall, and the instruments should not come short in the very important area, which is the junction. In very tall patients or in very obese patients, we do put the camera trocar much higher, maybe even here, which eases the suprapancreatic lymph node dissection a lot, but would a little bit put us into trouble for the vascular pedicle of the stomach, because you have to look down and work down and overhead, which is kind of difficult. Now, this is the trocar positioning for the thoracic part. We use a left decubitus position, or semi-prone, because left decubitus position, and then we flip the patient a little bit more ventral sides. But on the patient, you can see that, especially in the thoracic part, the trocar position can look a little bit differently, because you can only use the intercostal spaces, and you are limited to this. So this trocar is the assistant trocar, and you can already see that in this operation there might be some trouble with this, fighting with this trocar, which is used for the camera trocar mostly. But you cannot freely choose the position, because the assistant port is put in the line of the thoracotomy, which is performed to retrieve the specimen and perform the anastomosis. So regarding the anastomosis, we retrieve the specimen through the mini thoracotomy. Before complete transection of the specimen, we perform the anastomosis, as you can see it here. And I want to share all the parts of the robotic and minimal invasive operation Ivor-Lewis esophagectomy here. This is robotically. The abdominal lymph node dissection, you have seen it before. It's quite similar to the gastrectomy, and certainly number 12 dissection. Now you can see that we're also using the energy device, not always the monopolar hook, but we do the same. We do the same with the esophagectomy. One important notice, because I know that now the gastrectomy specialists are wondering why we have to cut single lymph nodes. This is sometimes even very important for the safety of the patient, because you you will get the whole stomach through the hiatus and pull it up. And you cannot afford to lose any lymph nodes, which is only loosely connected to the specimen, while you pull up the stomach, because you only have a mini thoracotomy in the minimally invasive procedure. And it's very important that you will not lose any parts of the specimen which possibly harbors cancer. So this is the reason why sometimes this area has to be retrieved selectively, which is kind of a contradiction to en bloc resection, but it is only to the safety of the patient. And I think you can understand why it's even important to do this, not to lose any tissue in the stomach while you pull it up in the thoracic part. Okay, now we have the thoracic lymphadenectomy, the Carina with the robot. This is a very, very dangerous step of the operation because you cannot, there is always a bleeding and it's not very, very easy to control. You cannot use electrocautery liberally because you might put a damage to the right or the left bronchus, which does happen eventually. And we do believe that the robot has a little bit more precision in the lymphadenectomy there, but you can see we are also performing it with a thoracoscopic procedure. You can see the right pulmonary vein there. And you can see it becomes a little bloody over here, which is usually the case. And because you cannot simply bipolar every little bleeder in this area. You have to use compression and then very, very selective electrocoagulation. Now, this is also a very delicate area, the paratracheal area in the thoracic part. Again, we are using the electric hook for the lymph node dissection. We like it very much. You see the azygos vein, which is clipped here, which is one of the first parts of the thoracic part in the esophagectomy. You can see the esophagus over there. And we do perform it likewise in thoracic procedure. So this is the lymph node dissection towards the upper mediastinum, which is discussed if it's necessary for junctional cancer, but we do believe that there is a certain percentage of patients who benefits from this, and we cannot yet select the patients who do so or who would not benefit from the upper mediastinal lymph node dissection, so we have to perform it. Now, I want to share how we, some parts of how we perform the anastomosis. So this is kind of a hand-sewn purse string suturing. It's not a real purse string, but I think it's okay to call so. We call it Rendel suture. It's a German name, probably you wouldn't know. And this is very tricky in the minimally invasive esophagectomy because the moment you lock the stapler, it's not very easy to see. We do overstitch the circular anastomosis, and the last part that you saw now, we do a omental flap around the anastomosis. I want to mention that it is very important in this part. If you bring together the stapler, you should have to be very careful in the total minimally invasive surgery or esophagectomy that you have no tissue inside or between the two stapler, because you cannot grab around it or you cannot completely control it, which is kind of dangerous because you can see that the posterior part you cannot see. So I want to highlight this. Okay, so this was robotically. Again, we have the same step thoracoscopically. Same technique. We use 28 millimeter circular stapler for this. You can see that it's quite a high anastomosis, high interthoracic anastomosis above the level of vena acygos. And then we cut the specimen because we do introduce the stapler through it, so we do not have a crossing stapler line. Okay. We have also some experiments with laryngeal nerve, recurrent nerve monitoring intraoperatively. Unfortunately, I tested before, these videos are not working, but I want to invite you also to, you can use the same nerve stimulation system that is used for thyroid surgery. You can also use for the upper mediastinal lymph node dissection in esophagectomy. Now, this is how it looks directly after the operation. I think this is a very, very acceptable result regarding the operation trauma. And you can imagine that this thoracotomy is only done for the very last step of the operation, so not for a long time. And it is much different to the open thoracic part, where you immediately have a much, much bigger thoracotomy, and the patients suffer much more pain and have a higher rate of pneumonia postoperatively. Now, this is 3 months after minimal invasive esophagectomy. You can see that the condition of our patients is quite a little different, because we call this a slim patients for the patients who come for esophagectomy. But you can see that the operation trauma is really acceptable. Now, I'm coming to the end, but I want to also share some results that we have gathered. Also already started before I came to Mainz. It is mostly done by my senior Professor Gruinger. And I think the results are quite acceptable, as we have had a uncomplicated procedure in 70% of the cases, and a leakage rate of 8% in the first 100 cases of robotic esophagectomy. We had one in-house mortality, which was due to a horrible oncological complication, as you see it here. And the leakage rate was quite low for esophagectomy, but even including the next 100 and next 150 cases, there is no series where it reached 15%. So I think we're having very acceptable results for this operation. Thank you very much.
Wow.
Thank you, Felix. Thank you for a very nice lecture. So again, we would like to ask you to wait until our last speaker, and for our audience to, if you have any questions to our lecturers, please type in the chat box, or maybe later in the open forum, you can ask your questions personally. So we'll be moving on to our last lecturer for the evening. I would like to introduce to you Professor Kim, who had his surgical residency at Chung-Ang University Hospital in Seoul, Korea. And he continued his master's and his PhD in the same institution from 2011 up to 2014, where he is an attending surgeon at the Samchok Medical Center in Gwangwon-do. From 2014 to 2017, he had his clinical fellowship at Seoul National University Hospital, the gastrointestinal division, where he became the clinical instructor at Gyeongsan National University Changwon Hospital. He is an active member of several societies, and he holds officership at several societies as well. He is the current Secretary of International Affairs of the Korean Gastric Cancer Association and the Secretary of Research for the Korean Laparoendoscopic Gastrointestinal Surgery Study Group. He has been a member of the International Gastric Cancer Association, Society of American Gastrointestinal and Endoscopic Surgeons, the Korean Surgical Society of Obesity, the Korean Society for Study of Obesity, the American Obesity Society, and the Korean Society for Metabolic and Bariatric Surgery. He is an assistant professor of the Department of Surgery of Gyeongsan National University College of Medicine and the Gyeongsan National University Changwon Hospital. Doctors, please welcome Professor Tae-Han Kim. Professor?
Yes.
Okay.
Yes, thank you for such a kind introduction. Today, my talk is about the adaptation after distal gastrectomy. I would like to thank Dr. Ang and the board members of the UMIST for the opportunity to speak today. Okay. The age standard incidence of gastric cancer in the Philippines is nearly 1/8 compared to Korea, Republic of Korea. However, the age standard incidence, the disease-related mortality rate is only half of Korea. This is maybe because relatively the majority of the Philippine patients are diagnosed advanced gastric cancer. According to the guidelines, the laparoscopic oral for patients with advanced gastric cancer, radical gastrectomy is recommended with radical lymph node dissections. And we all know that these situations are familiar that we only have two options, total or not total. The patients are curious, but what happens next? There will be a change in the alimentary tract, and therefore diet volume as well as habits should change, resulting in a change in the body weight and finally change in the body composition. In our center, in order to understand this phenomenon, we designed the observational study. The aim of this study is, the title of this study is the investigation of diet recovery after distal gastrectomy. The primary endpoint was to investigate the adaptation process of the alimentary tract after distal gastrectomy and understand the impact of the remnant stomach volume on diet recovery. 80 patients were enrolled prospectively between 2009 and 2012. We performed gas distended stomach CT scan preoperatively 1 month, 3 months, 6 months, 12, and 24th month after surgery, and measured the internal volume by measuring the stomach in 2 dimensions and integrated the volume with a 3D software to calculate the volumes of the stomach. And we performed the upper GI series of fluoroscopy to see the remnant stomach versus small bowel transit time. And we divided the parts of the alimentary tract from the upper part and the lower part. And we collected the transit time of the oral to EG junction and EG junction to GJ junction and the remnant stomach area and the small bowel transit time also. These are the main demographic outcomes of the patients that were enrolled. 80 patients were enrolled and not much difference of variation was found in our demographic outcomes. In the results, after some decrements over time, the nutritional indices reached nadir 1 year after surgery, and digestive functions recover over time and reached a maximal level at 1 year after surgery. So what we can anticipate is that after over the first year, patients will have severe weight loss, have malnutrition phase. However, it will eventually recover after a year. And for the transition time, it is from esophagus to GJ junction. It did not show much difference over time, but however, the small bowel transit time has been decreased through the year. And therefore, adaptation after gastrectomy mainly lies in small bowel recovery. And for the adaptation after gastrectomy from large versus small gastric volume, the remnant gastric volume of the larger group showed a large gastric volume throughout the study, larger than the small group. However, the diet intake, diet time, and body weight did not show any difference over time. So diet volume, frequency, time length per meal, body weight showed no difference. However, the gastric volume was larger in the larger gastric volume group. From this study, we found that patients who underwent gastrectomy reached 80% of diet intake than before the operation in post-operative 1 or 2 years. And mainly this decrease was most severe immediately after the surgery. Adaptation of diet intake after gastrectomy may be relevant to the adaptation of the small bowel motility rather than the gastric volume and stomach motility. How about body weight? Body weight losses were about 5% and 8% and nearly 7% at discharge, 6 months and 1 year after surgery. From the data that was collected from the Seoul National University and was published at Journal of Clinical Nutrition in 2014. After the gastrectomy, the gastric patients' diet volumes was decreased to 30 to 40% after distal gastrectomy, and approximately 10% body weight is recovered within 1 year after the surgery, which was similar to our data. And the extent, and this is a prospectively study conducted from the Sloan Catering Group, and from these 376 consecutive patients who underwent resection for gastric adenocarcinoma were analyzed and showed that the extent of weight loss after gastrectomy for gastric cancer is dependent on preoperative BMI and extent of gastric resection. So we can anticipate that those patients who underwent total gastrectomy goes under the most severe forms of body weight loss compared to the subtotal of Billroth 2 and Rowan-Y groups. And those patients who had preoperatively higher BMI showed rather more severe form of body weight in the early gastric cancer group. And as for those patients with advanced gastric cancer, patients show more severe form of body weight. So, and what we can learn from in this study is that maximal weight change expected by 12 months after operation, and they will hit a place where will be stabilized or improve over time. And what is even worse for those patients who underwent gastric cancer, gastrectomy, is those patients who form sarcopenia. Because sarcopenia itself is associated with severe postoperative complications, especially in those with elderly gastric cancer patients undergoing gastrectomy. This is a prospective study from the Japanese group. The overall complication, non-SSI complication, was worse in the sarcopenia group, and cardiac complication was also increased in these patients with sarcopenia. So naturally, there were many efforts to recover weight loss after surgery. One of the popular efforts was to feed patients with high protein and fat oral supplements. This was a prospective randomized controlled trial from Korea conducted by Professor Hyuk-Jun Lee from Seoul National University, but gastrectomy patients show no benefit from oral nutritional supplements compared to those patients who underwent colon surgeries. And patients who underwent gastrectomy showed compliance was also low compared to other colorectal patients. And naturally, total gastrectomy patients showed the lowest compliance compared to other groups. These effective nutritional intervention on nutritional status have been reviewed by lots of meta-analysis and systematic review. And as a result, there were no significant improvements in albumins and other transferrin prealbumin and other nutritional indices. And there were no increase in skeletal muscle, and no difference were found between the control versus the oral nutritional supplements groups. So to go beyond this situation, and it goes without saying that muscles are built from exercise, not only by eating. So we designed a pilot study to see the effect of perioperative physical therapy on gastrectomy patients. So we designed this study. It's a study to investigate the nutritional benefit of exercise-based rehabilitation program on early postoperative phase after laparoscopic gastrectomy. The patients who were diagnosed with early gastric cancer were enrolled for this study, and patients who required any chemotherapy, prolonged NPO due to complications were excluded. Due to the, in order to remove all the bias, we performed only Roux-en-Y gastrojejunostomy in all these patients, and the patients who were enrolled were all in the Gyeongsang National University Hospital, which is a regional cancer center. And patients who missed more than 50% of the exercise were considered a low compliance group, and those patients who were within the 50% of the exercise, they were considered as high compliance group. And these high compliance and low compliance groups were compared in nutritional indices and postoperative complications and other factors too. So this is the rehabilitation program. We performed daily 3 sets of 15 repetition of 5 different exercises 2 weeks before the surgery, and 4 exercises during 4 weeks after the surgery. And these exercises were mostly based on the lower extremities with the gluteus and quadriceps muscles that were comprising most of the muscle mass of a human being. And for the nutritional factors, patient nutrition status was checked with nutritionist consultation at preoperative 2 weeks and every week and every month after the surgery. Oral nutrition supplements were provided when patients were seemingly have less oral intake, less than 15% of required calories. Study variables such as demographic factors, clinical factors, face angle, body weight, and laboratory profiles were investigated. The demographic overview showed compliance of 17 patients who were compliant, and 8 patients who showed lower compliances. And from the laboratory test, the higher compliance versus low compliance patients showed no difference in cholesterol, serum albumin, and serum protein level. However, from those patients who had higher compliance showed a body weight loss compared to the low compliance group, and lower fat loss and lower skeletal muscle loss compared to the low compliance group. So our gastric cancer rehabilitation nutrition support program were tolerable among participating patients, and compliance group showed less decrease in skeletal muscle and total body fat at 6 months after surgery, according to the body impedance test. Total body weight showed an attenuated tendency to decrease after support program, however, did not reach a significant statistical difference. There were no difference in laboratory outcomes reflecting nutritional outcomes. However, in our study, it suggests that perioperative exercise and nutritional support program altogether has the potential to reduce sarcopenia and improve clinical outcome in patients with gastric cancer. Further trials with higher volume should be conducted for better clinical evidence. And this is a European study. It's an ongoing randomized trials, and the results are waiting to be addressed. I think we'll have much better evidence and higher level of evidence to support the benefit of perioperative rehabilitation program. And this is a summary of my talk. Gastrectomy is the mainstay in treatment of gastric cancer, and weight loss is 80% which is recovered 1 year after gastrectomy. Weight loss is associated with the extent of gastrectomy, and preoperative nutritional status is important for these factors. The size of remnant stomach shows no rule for nutritional benefit, and adaptation of small bowel motility is a key factor for recovery after distal gastrectomy. The postoperative weight loss leads to sarcopenia, which is critical for early and late postoperative outcome. Sarcopenia cannot be prevented by oral nutritional supplement, but attenuation can be anticipated by intense muscle growth-based physical therapy. Therefore, ladies and gentlemen, effort to avoid total gastrostomy is important, and small remnant gastric volume is equal to large remnant gastric volume. So you should not be disappointed when we only leave small stomach volume behind. Comprehensive treatment package involving nutrition and exercise is recommended perioperatively. Thank you for your attention.
Thank you, Professor Kim, for a very nice lecture. So we do apologize. We were supposed to have another speaker for you, but for this evening, since Professor An is still in surgery, we would move his lecture to the next week. So now we would like to invite our participants, if you have any questions, to please raise your hand, or so we can unmute you, and we can you can ask your questions to any of our speakers.
I did
Hi,
already
excuse me.
answer some questions below. I typed it in. I'm not sure if everybody can see.
Yeah, we noted. We noted. Yep.
Good.
So,
Can I ask a question? Can I ask Felix a question?
Sure. Hi.
Okay. Good evening. Hi, Felix. Nice to see you again. I'd just like to ask. You presented some data regarding your usage of float versus your cross.
Yes.
Can you share with us the experience of your patients with regards to which among the two regimens are better tolerated, or how are your outcomes with regards to both, and more or less how do you select which regimen you will offer to your patients?
This is a very important question, because when it comes to the junctional cancer, both regimens are effective, and because we didn't know how to select the patients, our colleagues from Freiburg, Germany, started the prospective randomized trial to randomize the patients for cross or flot. This trial finished recruiting maybe 4 months ago, but certainly it will take another 3 years of follow-up until we know the results. Our experience is that in the beginning of flot, the chemotherapy was not so very well tolerated, but after the oncologist had more and more experience with this chemotherapy, the patients came to the operation in a better and better condition. So I think maybe 3-4 years ago, my opinion was maybe cross is tolerated better, and then the patients go after operation, they go to a follow-up, they don't have any more therapy. But we do know that the neoadjuvant regimen of flot is the most effective. So now I have to say I prefer, if the oncologist feels comfortable with the flot regimen, I prefer for the junctional cancer, adenocarcinoma, I do prefer flot chemotherapy. And even if the 4 postoperative cycles cannot be given completely, I think you have a good chance of a response.
Thank you. Thank you.
we have a couple of questions in the chat box from Dr. Ramon de Vera. For Professor Kim, do you observe ERAS protocol with your patients?
Oh, actually, I was typing this, but instead I'll just go live. I don't know. We don't usually follow all the ERAS protocol. For instance, I'm not very confident and not much evidently secure that patients are allowed to consume water right after surgery or have early feedings the very next day. I believe some surgeons might not disagree, but I feel more comfortable for my patients to be monitored in the hospital for a few more days compared to ERAS patients. And because it's not very expensive in Korea and as well as also in Japan, the hospital fee is not that burden to the patients. So I recommend them to stay in the hospital a day or two. I don't rush my patients for early recovery, but I do my best to have them much more better experience in a hospital. Thank you.
Thank you.
And
There's
I'd like to
also
say that your program is not a contradiction to ERAS, because if the patients stay longer in hospital, but they do have a good program as you introduced, they benefit longer from the program as they would probably at home. So it is another argument for you to have your patients.
Yes, thank you very much. That's the whole idea. I'd like to provide some better programs for the patients and not just driving them away to their homes.
Yeah, noted. There's a comment in the chat box from Dr. Ramon de Vera. In his experience with the pylorus preserving gastrectomy, that when he inserts a tube beyond the pylorus, the patient is able to feed earlier. So you do not have any delays in the gastric emptying time. Professor Zhou, do you have any experience of doing, or do you routinely place an NGT and pass it beyond your pylorus so as not to have the delay in the gastric emptying time? How about with the other speakers? Do you
Okay,
do it?
I would like to jump in. So I would probably not answer the question specifically, but what we do have the same problem with the delayed gastric emptying after esophagectomy, right? So it's the same discussion as after PPG. How do you manage delayed gastric emptying, and how does it occur, and how can you reduce the rate? What we do is, and I wanted to mention, but I forgot during my talk, what we do routinely in preparation of esophagectomy, the day before we perform esophagectomy, the patient undergoes endoscopy, mostly because we have to restage after the primary chemotherapy or so. So we see the cancer. And then we do a endoscopic balloon dilatation of the pylorus. Which can be done with a 20 centimeter or even 30 millimeter, 20 millimeter or 30 millimeter balloon, which is placed in the pylorus. And we observed that the rate of postoperative delayed gastric emptying was reduced by this measure. And I also want to answer for Dr. Chu and maybe also for Professor Kim, because they both together very successfully published that a manual dilatation can also be done intraoperatively, if so ever possible. So if you can get a clamp into the pylorus and you can make a maneuver to dilatate, it would probably reduce the rate of delayed gastric emptying. If you place a nasogastric tube beyond the pylorus, certainly you will pass the problematic area, but I'm not sure if you will improve the function, because it's a functional problem, and the functional problem will not be solved by the tube, but certainly you will not have a delay in having a sufficient nutrition for the patient.
Okay.
I would like to add some comment on that. In Japan, they don't do any procedures to cure or attenuate the delayed gastric emptying, because they like to have patients more than a month after the surgery. And the problem is that, the thing is that this delayed gastric emptying, if you do not have a direct injury of the infrapulmonary vessels or neural damages, then it will have a spasm that will stay there for about 2 weeks and 4 weeks maximum. 50% of the patients resolve this problem after 2 weeks after post-operatively. So actually, if we can endure those and make any maneuver that can bridge that 2 weeks, then it can alleviate, or how do you say that? We can relieve the patient from the delayed gastric emptying symptoms. So that is important. Therefore, in some patients, in some centers, they put a Botox injection nearby the pylorus, so they have a dilatation for 1 or 2 months, so they don't suffer from the delayed gastric emptying.
Okay, thank you. So we have a couple of questions that were answered by Dr. Berth, but I would like to go over them so that for the benefit of our other attendees.
Yes.
So Felix, there was a question for you that said, what's your comment about your jejunal interposition for
Yes.
proximal
Yeah.
gastrectomy?
So there is for the resection of the cardia, there are different operation types working with a small bowel interposition. One method which was frequently used in Europe was the Marendino operation. I'm not sure if you're familiar with it. And we also performed it too, even a couple of years ago. But what we do experience is that in the follow-up, a significant proportion of the patients suffer from delayed interposition emptying caused by a redundancy of the jejunal interposition. And I do believe that this naturally happens because you have you still have a esophagus, which is a very strong muscle. You have a jejunal interposition, which is a very weak muscle, and then you have again a stomach, which is much stronger. So the interposition is in regards of the muscular power is not sufficient to bring through everything, and will be redundant. And as soon as you have a redundancy, you have a highly symptomatic patients. And what we experience is that we did even help the patients even after benign disease. So there is no cancer follow-up. But suffering from this redundancy, we help them by doing a esophagectomy secondary. And the gastric pull-up was functionally much better than the jejunal interposition. So now, even in benign cases where the radicality is not compromised by jejunal interposition, which is less radical than the gastrectomy and less radical than the esophagectomy, still we hesitate to do so because we do fear that the functional outcome is not perfect.
Okay. There's another question for all the speakers. How do you handle your anastomotic leaks?
The best way is to not have some. But as I showed the data, we do have some, and probably I would directly say that we probably in Europe would have a higher rate than you have in Asia in the highly specialized centers, high volume centers, which is mostly due maybe to the surgeon, but also maybe a little bit to the patients. We do routinely perform endoscopic treatment of leakage, both after esophagectomy and gastrectomy, which contains endosponge therapy, which is a sponge that you bring in the leak, and you have a under pressure, a negative pressure, which helps to the granulation, and it sucks out the fluid and all the dirt that is going through the leak. And certainly the second option that is frequently used is the stent, which can be used, which we do prefer now if there is a very small leak with no abscess beyond the leak, then it's just a very good thing to close the leak by stent, and the patient can very soon after, if the stent is sufficient, the patient can drink and a little bit eat. But if the leak is very large and there is a large cavity, then the sponge is preferred because we can put it even in the cavity and suck out all the fluid that is running there, and we can keep the wound cavity clean. Yes.
And I would like to add some of my comments. Number one, when we encounter leakage, the most important question we have to ask to ourselves is whether we should open the stomach again, whether we should go under a second surgery. Most of these times recently, these surgeries are only indicated when patients have a total disruption of anastomosis, or in those cases where bleeding is encountered on top of our leakage, because in some cases our gastric fluids or digestive fluids come out and they melt these kinds of the clips or any clots that were used for the hemostasis. And when these are compromised, then we have to make a very decisive judgment call for a reoperation. And if it's not in those cases where catastrophic cases where reoperation is necessary, then we have to ask ourselves whether we should perform an intervention. So in those cases, if this leakage is minor, then only percutaneous drainage is necessary with prolonged NPO with a peripheral nutrition. However, in those cases where percutaneous drainage is not accessible, there may be some interventions such as Dr. Berth recommended. Those endoscopic approaches might be needed. However, most of the time, when we do not perform a reoperation, most of the cases we can salvage the patients. But and sometimes when we do a reoperation, in those cases with leakage, the results might not be very optimistic in those times. So you have to be very decisive when we encounter these patients.
I totally agree. And for the esophageal surgery, there is specific results showing that reoperation routinely performed on leakage highest the mortality of the patients. It is a good thing to do if you have early leakage after esophagectomy. That means in the first 2 days of 48 hours, which is highly suspicious for a technical error. Then you can re-anastomosis or even oversuture. This can be done by a surgical maneuver, but any other surgical maneuver on later anastomotic leakage should be performed carefully and selected carefully, because I totally agree with Professor Kim that we most of the time, even if it's not necessary, or we even impair the outcome.
Professor So, do you have anything to add?
Me?
Yes, you.
Okay, it's a very good chance. Actually, it's a good chance for me to meet 3 of my very good friends, Dr. Kim, Dr. Felix, and Dr. Ang here. So it's my appreciate. I'm very appreciative that invite me here. So I think this teleconference has a very good, successful result. So thank you very, very much again. And hope everyone here can be safe, and all of them can have a happy life. Dr. Ang.
Yes, I totally agree.
Okay, so we'll move on. There's another question. For the double track reconstruction Felix, do you do your pyloroplasty,
No,
or
no, no. This is
there's
the
no
same.
need to do it?
No, this is probably the same as we talked about the pylorus problem after PPG or esophagectomy. For the double tract, we do not perform pylorus dilatation. We considered, and probably we will simply try to do this, but the benefit of the double tract, as it is a double tract, we do not depend on the gastric passage. So even if there is a transient pylorus problem after the operation, I think the main outcome of the patient will not be impaired. But certainly, so pyloroplasty, I wouldn't think about it, because it's another opening of the lumen that you perform in the operation. But I think a maneuver to make a simple pylorus dilatation, it wouldn't harm the patient too much, and possibly you have you have a good gastric emptying right away. Why not?
Naturally, if you're doing the surgery right, doing the dissection right, then you have to have a pyloric spasm after the surgery, because you are dissecting all the vagus nerves too. It's
That's
still
right.
different from the PPG. So in this case, we are not anticipating for the fluid materials to go down to the antrum to the pyloric opening. We're just leaving the antrum to secure other functional effects of the stomach, not the digestive part. So it's not necessary for us to restore the pyloric function at the moment. Yes.
That's right. But in esophagectomy, you cut the
Right.
vagus nerve too,
Then,
and you
Yeah.
do not have a pylorospasm in every case. So if you don't do anything, and you cut the vagus nerve, you have a rate of in our patients a rate of maybe 30%. So that's another argument not to do a too active maneuver, especially in the double tract. I wouldn't.
so purpose of maintaining your pylorus would be for physiologic purposes, like for preventing pernicious anemia.
Yes.
That's one of the benefits of
Yes.
maintaining your antrum. Yep.
Yes.
Okay, noted. So there are a couple more questions from Dr. Layson. How about pyloric exclusion? Do you do such surgeries? Dr. Layson, can you clarify your question for us? Maybe we can unmute Dr. Layson so we can further clarify his question to the speakers.
I don't see the question.
Boss?
Oh wait.
Yeah.
Well, actually, the pyloric exclusion itself is performed when we have a, ulcer surgery, ulcer, severe ulcer at the proximal duodenum, or a duodenal cancer situation
Yeah.
where we need to bypass the first portion of the duodenum. But in this case, where we have a very high level of GE junction cancer, then I don't think pyloric exclusion is necessary.
Is Dr. Layson here? Does that answer your question, sir? Okay. I when I saw the operations, the videos, I saw the difference with what Felix does and what I was observing. Do you routinely use your circular stapler for anastomosis, or do you use a linear stapler? Is there a higher risk of incurring stenosis with the circular stapler when you do your esophago J, or your esophagogastrostomy anastomosis? So
You mean
which
in
type
gastrectomy or in
of
esophagectomy?
staplers? With when you do your anastomosis, connecting your
Yes.
esophagus to your jejunum, do
Ah,
you
okay.
always prefer doing your circular stapler, or do you sometimes do a linear staple? Use a linear stapler?
No, we tried technique simply to experience with it because it's described also to be safe and a good technique. However, we are very familiar with the circular stapler, which we also use in the esophageal resection, and we have good experience with it. The only thing is that I have not yet found the perfect technique of esophagogerostomy that I can perform in every case, because we have a high incidence of cases, relatively high incidence, where the anastomosis has to be extremely high. And in those cases, you cannot easily perform a Hansun purse string, because you have to reach the lower mediastinum, and the angle is quite horrible. We do not like a double stapling. So we do not like crossing stapler lines naturally, which can be done by Orville or a double stapling, or the hemi-double stapling technique that I have seen also in Korea and SNUH, by bringing in the anvil before transecting, and then bringing out the anvil by a needle and pulling through the anvil tip. But still, it's the principle is a double stapling, and with this technique, you have to spare 1 centimeter of proximal margin, which we cannot afford in the very, very high cancer locations that we see often. So we tried out a lot of different techniques, but I have not yet come to any conclusion which one is the best or the safest. There is reports and studies. I think the Memorial Sloan Kettering colleagues doing the linear stapler and favors it because of the safety. But the anastomosis is performed openly after the minimal invasive gastrectomy. I think our experience with a circular stapler is okay. And if I find the perfect technique that covers all cases, I will let you know immediately.
Yes, I
Thank you.
agree with Dr. Felix. And the best way to make the anastomosis with extremely high would be the circular stapler. But regarding the EJ stenosis, I think the linear stapler has more advantage compared to circular staplers. So, but every technique has its own way. So we have to still see what's more feasible depending on the patient's condition. Yes.
Okay, noted. How about in China? Which do you prefer, the linear or the circular stapler, Professor?
I don't know for the for total gastrectomy laparoscopically, most of the Chinese surgeons prefer linear stapler. Actually, when I was studying Seoul National, most of the total gastrectomy, the anastomosis is used anvil to make using circular stapler, but the Chinese surgeon is surprising me when I go back to China. I find that most of Chinese surgeons, they prefer linear stapler in total laparoscopic total gastrectomy.
Even in Korea, only the Seoul National Group use the circular stapler.
Okay.
Yeah. So you have to be careful what you see. Okay?
Are there any more questions from our attendees?
How about you, Guy? What do you do? Circular or linear?
Sir, I think I do the linear because that's what I observed with when I was training in Seoul.
How about you, Emo?
Yeah.
See?
You're on mute, Emo.
same with Duday. Yeah, we like the delta anastomosis. But when doing esophago J open, I think we are more used to the circular, the open when we're doing it.
I find it the incidence of stricture is less in my experience on if you're doing your linear stapler. And then rather than do a delta, I would hand suture it. So the anastomosis is quite huge. And every time we do our endoscopy after a few weeks or few months after the surgery, you'll find a very nice anastomosis and a more relaxed anastomotic area. So the incidence of stricture is quite low. So even when I was doing my total gastrectomies and Ronson was with me, he would always ask me, why not do the delta? I said, every time I do a delta, there seems to be some stricture in that area. And it's quite, so I said, I'd rather do it hand suturing. So it's easy also. So it gives you some practice. I don't know. It's just my own personal experience.
I think for the anastomosis, the personal experience which comes along with the safety of the anastomosis is the most important. But after gastrectomy, we do not see significant. The stricture is a significant problem. We do also sometimes use, or if it's possible, and it is possible in a good proportion of patients here, we do use a 28 millimeter stapler even for the gastrectomy, which is certainly not always possible regarding the size of the person and the size of the bowel. But we try to have the similar techniques for all the similar anastomosis to have more practice and to have a good standard. So in esophageal surgery, we have to do it because if you remember the thoracoscopic anastomosis that I have shown in the video, you have seen how high intrathoracic the anastomosis is. There is almost no way to do it with a linear stapler. In that sense, we do also prefer the circular stapler after the gastrectomy. And I think in Europe it is much more common.
Very true.
Professor Kim, from what I've seen in your introduction to your study, it's not the actual gastric remnant that has a problem. It's your small bowel that has a problem. So how do you postulate, since when we do the surgery, we only manipulate the stomach, how come it's the small bowel that has a delay in the motility?
Well, at the end of the day, what matters most is the vascularity of the remnant organ. After gastrectomy, we only leave the short gastric artery and vein behind. So there's not much room for the stomach to act properly. But when we make a proper anastomosis with the jejunum, in our study, we only use the Roux-en-Y anastomosis. But what we've seen is that as time goes by, the small bowel action became more vigorous and they were more active than the immediate post-operative phase. So at the end of the day, what's really important is short gastric artery, and second of all is what kind of small bowel the patient it has from the beginning, what he has from innate digestive function. So patients who were very able to eat big meals, fat meals without any gastric problems, those patients will eventually have very small weight loss. But those patients who have digestive problems from the beginning will have much more probability of having a bigger weight loss.
Thank you. So are there any more questions from the group? Anything to add?
For Dr.
Okay.
Chu, good evening. Thank you once again. Maybe you want to share your two very important studies. First, on the pylorus preserving gastrectomy, for upper third, for tumors located in the upper third of the stomach. And the second, your 3D volume rendering program, which will guide you in the splenic or suprapancreatic lymph node dissection.
Okay. So I have published a paper with the help of Dr. Felix and Dr. Ang. So the paper is just about the upper third PPG. When the tumor location is involving the upper third, I don't mean the actually upper third. It's involving upper third. If the lesion, the tumor lesion is, there still has distance to cardiac, it will be has some chance to do porous preserving gastrectomy. So after surgery, with our clinical analysis, we can see that the clinical data shows when we do porous preserving gastrectomy for these upper third patient, the oncological safety can be proved. So when the tumor lesion is more than 3 centimeters apart to the cardiac, we still have chance to do porous preserving gastrectomy, and it will be benefit the patient to avoid total gastrectomy. Thank you. Dr.
Yeah, thank you, Dr. Chu.
Ist der Peter am Tisch? Okay. Weißt du zufällig, ob wir die
For Felix?
das Streamline-Kabel für
I think he's on the phone with somebody else.
Yeah, I think there's one question from Dr. Ramon de Vera.
Okay. I think this one's directed to Professor Kim. Professor Kim, with regards to bowel motility in your Roux-en-Y, well,
I'm sorry,
the question
I'm
just
again.
disappeared. Sorry. There was a question from Dr. De Vera. I think it's with regards to bowel motility in Roux-en-Y. Dr. De Vera, what about bowel motility? Can you comment with regards to bowel motility when you do your Roux-en-Y? I don't seem to understand how the question goes, but
How about your experience on uncut Roux-Y, Felix, Professor Kim and Professor Chu?
Yes.
Hello, Duday?
yes, sir.
Hindi,
You can
sorry.
ask your
What
questions
I mean,
directly, sir.
yeah, kasi I put in the chat box that I'll make a comment. The reason why you have a problem with bowel motility in Roux-en-Y because you have cut the circuit that supposed to be when you cut through the mesentery, when you create the Roux-en-Y, the neural transmission start from. So when you create a Roux-en-Y, you cut that circuit. So I think they've made already, I've read in some journals that there would be motility problems associated with Roux-en-Y because of that, what you did by interrupting the propulsion of the impulses from the duodenum down distally. So when you interrupt that by creating the Roux-en-Y, that is transecting the bowel, the mesentery to create the Roux-en-Y, you interrupt that propulsion of the impulse from the duodenum to the distally, and that's why you'll really have problems with motility. I think there were journals in the past that were made on that issue.
So in those patients where we investigated the bowel motility, those patients only underwent Billroth 2 anastomosis without any division of the small bowel or mesentery. But in another series of analysis, we looked into those patients who underwent Roux-en-Y anastomosis with jejunal resection and mesentery division. Actually, the rate for Roux stasis syndrome was nearly zero. There were no cases that developed any Roux stasis syndrome. So, so far, reviewing 200 patients of Roux-en-Y so far. Maybe we need much more larger volume of patients to realize what patients will have Roux-Liszt syndrome. But so far it was okay, and I think maybe it was because of the is a sufficient length of a roux or limb that was put over for gastrojejunostomy. Yes, thank you for your comment.
Are there any comments from the group? Anything you want to add?
Bernice,
From our chairman? Yes, sir.
Bernice, may I ask a question to Professor Felix?
Sir.
Felix, sorry. Question is, you have a protocol of pre-op chemo, then you do your surgeries. What's the time interval after the surgery? What's the time, and then you complete chemo right after the surgery, right? What's the time? Yeah.
So the most important interval is after the neoadjuvant chemotherapy. Then you have to wait for at least 4 weeks. And we don't have data that in the period of 4 to 8 weeks, there is a advantage or disadvantage if you make it quicker or longer. Some patients in a very good condition, there is no need to wait longer. Some other patients probably would benefit from waiting 2 weeks longer to improve the physical condition to go into the operation. And after the operation, we usually use a interval of about 6 weeks. But this is also, this is the bigger problem actually, because the postoperative chemotherapy cannot be performed on every patient. And then we do have a lack of evidence. If the interval becomes too long, then we don't have then we can make the first follow-up already. And if we don't see anything, probably there is no evidence that the postoperative chemotherapy has to be performed anyway. So either you perform it after 6 weeks, or probably you don't perform the postoperative part. But the studies that had been performed also highly suggest that the 4 cycles before operation are much more important than the 4 cycles after operation. But I think this only comes along because this is the first 4 cycles that are put on the tumor. So if you follow the Asian way to do surgery first and then adjuvant chemotherapy, I don't see any reason why the chemotherapy would work less. And the studies in Asia suggest also that it works very well postoperatively. And I think it has something to do with the first 4 to 6 cycles is maybe the most effective.
Thank you, Felix, for that. Just to follow up with that, after your last chemo, you monitor your patients on a 6-month interval or a yearly interval? Because usually, I'd like to know the time of recurrence. I mean, from the last, I mean, the timing or the length of the recurrence of patients, and how do they present if they present with either local or distant metastasis or recurrence?
So we do follow up our patients with a standardized protocol. In the first year after operation, we see the patient every 3 months. And we have at least 2 CT scans performed in that year, and usually also 2 endoscopies. Then in the second year, if there is no recurrence, we see them every 6 months, and from the 3rd year on, once yearly, with a CT scan and endoscopy. And we do react individually to any kind of recurrence. So we do discuss it in the so-called tumor board, so interdisciplinary discussion. The proportion of patients becoming again surgically in the recurrent situation is very low. Because in that situation, clearly it's a systematic disease which requires systematic treatment, which is chemotherapy. But we do see some success maybe with let's say targeted drugs that can have a very long effect on the recurrence, or a very good response, or the immune therapy. And then now we see more and more patients, they have a recurrence, which is clearly systematic, but they have a very, very good response. And then one single metastasis remains and everything else is gone. So it's highly, so they suggest us to just resect it. And we have to be very careful with it. But of course, for young patients, an individual decision can be made. But those patients becoming surgically, the percentage is very low.
May I ask the same questions to the other professors? Do you see that kind, the same recurrence rate or a very low recurrence rate for your local recurrence for your patients, Professor Kim and Professor Zhao?
Yes, after the surgery, we always follow a patient in 3-month interval, and we perform a 3-month interval CT scan for about 2 years. And then after that, we elongate the interval for 6 months for about the next 2 years. And actually, I don't see almost a very rare local recurrence, and most of the recurrence are basically peritoneal recurrence or malignant fluid recurrence. But in those cases, we refer the patients to the medical oncologist for the secondary and third line of chemotherapy. And actually, at that situation, there might be another option called HIPEC, peritoneal chemotherapy, but we're not performing HIPEC in our center at the moment. Yes, thank you very much.
Thank you for that, Professor Kim. Uday, thank you.
Yes, sir. So we've been at this for the past 2 hours. So would you like to make some more comments before we leave let our speakers go? This has been a very fruitful session. Maybe you would like to have Dr. Buenafe and all the chairmans of the other departments to have maybe a closing remark before we end this session.
Thank you very
Sir,
much.
would you?
Sorry, sir.
Yes.
I'd like to thank Professor Felix, Professor Kim, Professor Zhao for this night, and I'll defer the closing remarks to Dr. Benafe. I'll pass the mic on to Dr. Allen. Allen?
Yeah. I would like to thank, of course, Professor Chincho Zun, Professor Taihan Kim, of course, Felix, for sharing your time with us. And it has been a fruitful evening. We've learned a lot from the 3 experts. We're sorry we weren't able to get through with Professor An because of some emergency surgery that he has to do tonight. At the back end of it, we would like to thank our team, our gastric team from Dr. Ronson Ang, Dr. Bernice Navarro, and of course, Dr. Edmond Orlina. I would like to call on Dr. Abari, Romeo Abari, the chairman of the Department of Department of Surgery for Quirino Medical Center, to give us the closing remarks. Dr. Abari? Sir?
Yeah, good evening, Alan, and to our distinguished lecturers. Indeed, it was really a fun night, even though it's raining here so hard in Manila. So we really enjoy our discussion, and really tons of ideas are coming up. And while listening to the different discussion, I really envy those countries that really had um could catch their patients at an early stage of gastric CA. Unfortunately, here, especially in government hospitals, we usually catch gastric CAs to their very late stage, so that most of the time we could not do anything but do only bypass. So it's really nice to hear from the experts what are they doing to improve the survival rate of early and even let's say locally advanced gastric CA. So with that, thank you so much, and we really learned a lot. And I would also congratulate. I would like to thank the team of the gastric team for such rendering this webinar. So with that, good night, everybody, to all the participants, and especially to our distinguished speakers, and especially Allen. Thank you again. It was really an exciting night. So with that, good night and thank you. Back to you, Allen. Thank you.
Thank you, sir. Anyway, good morning to, no, good afternoon now to Felix, and good evening to Chinchao and Taihan. Thank you so much for sharing your time with us. Thank you.
Thank you very much.
We'll see you again next week for the last series of the gastric lectures. Thank you.
Anytime. Thank you very much.
Felix.
Thank
Yeah.
you. Good night.
Thank you so much.
Pasmal, thank you.
Thank you.
Be safe.
Thank you. Good night.
Bye.
First to
Po,
stay happy.
salamat.
Salamat po.
Thank you, Duday. Thank you, Emong. Thank you, Ronson.
Happy
Salamat.
birthday,
Thank you,
Kevin.
sir.
Look
Happy
at the-
birthday, Kevin.
Happy birthday, Kevin.
Boss Ronson, salamat.
Happy birthday,
Ronson,
Kevin.
thank
Good
you.
day. Thank you, Doc Emong. Thank you,
Bernie,
sir.
thank you.
Thank
Sir,
you, Doc,
salamat po.
Dr. Polines, Dr. Avery, Dr. Sarmiento, Dr. Banabe.
Thank you, Ronson.
Goodbye,
Doc
Dr.
Arlene,
Thank you all.
the rest of the UMI staff, PCAS.
Single pa ba si ano? Si
Congratulations.